Look, that's
Hi, good afternoon, everyone. We'll see if we get a few people coming in for the second part of the question and answer on COVID-19. It's April 13th, 2020, and thankfully, at least in Manitoba yesterday, we actually had 0 new cases of COVID-19. I see we're starting to get a few people coming in. Today I'm very pleased that I have an assistant working with me today that you're going to hear periodically. If there's any questions that come in, then we will have my assistant ring in with the type of comment that's come, and we'll do our best to answer it. And like yesterday, if a question gets asked that I do not know the answer to, that's fine. I can always look it up and communicate afterwards on the Facebook page. The other thing that I led with yesterday, and I think it's important to state up front, every opinion that I'm going to be giving here is my own. I'm not representing anyone, and really I'm trying to get the message out about the messages and the thoughts that we had when we put together our CPS. That's the Canadian Pediatric Society practice points on management of deliveries in the NICU and breastfeeding as well. And so what I would encourage people to do, if you're interested, if you have the inclination, if you want to post a comment with a question, I'm hoping to help dispel perhaps some myths and also put some people's minds at ease if possible during a time that of course is very difficult for everybody. One of the things that came up yesterday that I don't really think we got to touch on was when people actually should be using the N95 masks. There's been a lot of excitement out there about the shortages that are feared with the N95 masks, and I think it's important that people recognize what they're for. Excuse me, the N95 masks are for procedures in which you're going to see aerosolization, or there's a risk of aerosolization of virus in respiratory exhalations. So that would be, for example, with intubation. It could be with CPAP. It could also be in adults with NG placements, in which they might cough, at which time they are, or during the period when they're having an NG placed. We don't believe that this is true in newborns, and we certainly advise on the use of N95s if you're going to have any of these aerosol-generating medical procedures. But they are meant to filter out particles that are, in the, they will not allow particles in that are down to about 3 microns, which is really, really tiny. But your surgical masks will filter out just about all other droplet-sized particles. So we don't need to have an N95 for every single situation. I understand there's a question.
Doctor, we have a question from Shavana.
And the question is, please tell us about investigation of a newborn of a suspected mother. And thank you, Shavana. If you, and everyone who's listening, if you wouldn't mind indicating where you're from, out of curiosity to see how far this is going, that would be appreciated. So investigating the newborn of a suspected mother is a very interesting situation, because one of the things that we really need to bear in mind is that infants who don't have symptoms are possibly going to have a false negative. Essentially, if you don't have secretions, if you don't have anything that will contain the virus that you're suctioning up or swabbing with a nasopharyngeal swab, you might get a negative simply because you don't have secretions to actually sample. So that's one point that we need to think about. The second thing we need to think about is, what's the purpose of investigating the newborn? If you have a mother who's COVID suspect, then my personal advice has been to wait and see if the mom's test comes back positive. If she comes back positive and the baby's asymptomatic, there's really not much that one is going to do with that. If you have a mother, though, who is suspect, goes on to become positive, and then her infant at some point becomes symptomatic with coughing or pneumonia, fevers, lethargy, those sorts of symptoms, in those cases, what we would certainly recommend, or at least I would recommend, is doing a swab at that point and looking to see whether or not the infant is in fact positive, and that may be the reason why they're actually having respiratory distress. The second situation that you may encounter is a situation where you're looking for surveillance. We spoke yesterday about the continued desire to determine whether there's any true vertical transmission occurring. So if there is possible vertical transmission occurring, the way to detect that would be to swab as early as possible. We've certainly suggested in the CPS statement that this may be best between 1 to 2 hours of age. After first swabbing the infant's face, after first wiping the infant's face clean to avoid contamination if there's any virus on the infant's skin. Bearing in mind, though, that if the infant does not have any symptoms, as I mentioned, we may see a negative simply because there wasn't anything in the swab. But this would be a case, I think, where the infant, if they come back positive, gives us information early on that would be useful in the literature. And as I said yesterday in the first video, there's so many rumors circulating out there and sensational news stories about people claiming they've had positive newborns, but until we actually get something documented firmly in the literature, I think that for the time being, we believe, or at least I believe, that we're not seeing any positives of vertical transmission or transfer of the virus from mom to baby while still in utero. We have another question, I guess.
Dr. Nervu, we have a question from Elaine.
Yes? Elaine has asked, in your L&D, do you allow support people to wear a mask? And that's a hot topic about what to do with support people who are supporting families. And the support person, the current thinking on this is, I think that it's certainly under discussion, the idea of having support people wear masks. But I would unfortunately have to say that you'd have to check with your local IP&C to determine whether or not that was appropriate or not. I suspect the answer to that is probably very dependent on whether you have a lot of community spread in your area of the world. If you don't have a lot of community spread and it's generally limited to travel, then that might not be as useful, but certainly if you have a fair amount of community spread, that's a consideration for your hospital. We have a...
Dr. Nervu, we have a question from Mohammed.
Is it correct to do cardiac massage before proper ventilation by endotracheal tube? I think, well, that's a question that I think goes back to general NRP. I think that one of the things that we know about the newborn in resuscitation is that if you don't establish effective ventilation, you're not likely to be successful in restoring heart rate. So that would be something that I would endorse is, certainly getting that endotracheal tube in as quickly as possible. Having said that, if you are using positive pressure ventilation, if you have a mask in place and you can give that, and the heart rate is not coming up and you're struggling to intubate, I certainly would not delay putting the not delay the chest compressions. But even if you get an endotracheal tube in, please remember that because we're not using a cuff tube, at least I assume you're not using a cuff tube in the delivery room, there's still likely to be leak and aerosolization around that endotracheal tube, which is why certainly for in the unit, in the NICU, I think many places are considering using the N95 masks, but at a delivery, if vertical transmission is not thought to occur, getting that endotracheal tube in is probably not as critical, and I would not delay chest compressions.
Dr. Nervy, we have a question from Marcia.
Marcia, I remember you well. This is a question from Edmonton, where I used to work. Should we wear N95 masks in coughing infants who are not intubated or on CPAP? Marcia, I'm going to, what I will say on this point is, I'm going to give you an opinion. This one definitely you need to check with your IP&C for. But going back to my earlier comment, the N95 masks are designed to filter out very tiny particles above 3 microns. The coughing should produce large droplets, and those large droplets should be contained or should be prevented from you inhaling them with a surgical mask. If you are on CPAP or intubation, or the infant's intubated, the concern is that those particles could be quite small, and you would need the N95 for that. So, for a coughing infant, I think, again, you need to check, but a surgical mask may provide enough coverage in that circumstance.
Dr. Murphy, we have a question from Omar.
Let's see. Omar is Omar's from Miami. Okay. Welcome. Do you have a suggestion as far as controlling numbers of visitors, if any, in the NICU? Omar, you have probably touched on one of the hottest topics in the NICU, at least, is visitation. This is a very, very difficult topic to grapple with. We have, certainly if you go around the country, you'll see, and I'm speaking of Canada, I can't speak for the US, but you'll see different approaches to this. Our own approach here, where I am, is to limit visitors in terms of one parent or one care provider in the unit at any given time. If a mother's COVID positive, we are not having anyone visit. That is the mother or the partner until cleared by IP&C. And let's not kid ourselves. That is a very, very difficult thing for a lot of families. And I think there's a lot of concern about interruption of bonding. There's concerns about interruption of breastfeeding and normal processes. But I think in the grand scheme of things, we need to bear in mind that this is a condition that through social isolation or social distancing will eventually be crushed. And so I think this is unfortunately a case of short-term pain for long-term gain.
Dr. Irving, we have a question from Christine.
Hello, Christine. What is the criteria for a confirmed or suspected COVID mother to be allowed to visit her baby in an ICU after initial separation? Well, I fear I'm going to start to sound like a broken record in saying you'll have to check with your local IP&C, but you certainly will need to check with IP&C. It will definitely vary depending on where you are. But one thing's for certain, I believe you would need to be symptom-free for a period of anywhere from 24 to 48 hours as a minimum. I don't think you probably would have to have at least one, if not two, negative tests. But again, that would be dependent on the rules in your institution and what your IP&C thinks is most appropriate.
Dr. Harvey, we have another question from Afaf.
Okay. Do you recommend bathing a baby after stabilization? Great question. So when we wrote the CPS practice point, that was a very big topic because we've really gone out of our way in neonatology to try to delay the first bath because there is an increased risk of hypothermia, there's potential risk of hypoglycemia. And so on the one hand, we're arguing that we want to delay the onset of the first bath. And then on the other hand, intuitively you would think, why wouldn't you want to clean the baby in case the baby's covered in secretions which may have COVID-19. Fortunately, as I mentioned in yesterday's talk, we have one study that I'm aware of that looked at vaginal secretions and testing it for COVID. It was done in postmenopausal women, but all 10 postmenopausal women who had severe COVID-19 pneumonia tested negative. So that does certainly give us reassurance. I think at the very least, the baby's face needs to be cleaned with soap and water if you're going to certainly do a test of the baby. But otherwise, I think you're probably okay to still delay the bath because we don't expect that they have COVID-19 the coronavirus at birth.
Dr. Irvie, we have a question from, sorry if I'm pronouncing this wrong, Jillian or Gillian?
It would be, I believe, Jillian. Jillian, we are using surgical masks for all babies at the moment in NNU to protect the babies from us, not us from the babies. So I guess that's more of a statement. Okay. Karen has asked, many obstetricians are giving pregnant nurses early mat leaves due to risk. At what stage of pregnancy would you consider a pregnant nurse at highest risk? Should pregnant staff not be assigned to query or positive patients? Very interesting question. To a certain degree, I would defer that to an obstetrician to ask that or to answer that question. But given that we don't have one, I can tell you that one thing that very fortunately seems to be different than the situation with previous coronaviruses of SARS-1 back in 2003, 2004, and then the MERS virus in 2012. Both of those viruses caused fairly significant illness in pregnant women and led to premature birth. We don't tend to see the same thing with COVID-19. To that end, I think there was a New York Times story in the last 24 hours that broke, indicating that I think there's been 200 births in a New York hospital that I think have gone well in the last little while. And so healthy births can still happen. I'm not saying 200 births from COVID positive mothers, but we don't tend to see a lot of prematurity in pregnancy. So I do believe, though, that there are some recommendations in the UK, and there are some people online I know from the UK that have suggested, I think, that pregnant women after 28 weeks go off work, but I cannot verify that. But if somebody does know that and wants to post the answer to that, if that's what's going on in the UK, that would be great.
Dr. Irvie, we have a question from, again, I'm sorry if I'm pronouncing this wrong, either Sheer or Cher.
Oh, that's Sherry. Okay.
Sherry.
Have there been any ICUs with COVID outbreaks? So as far as that goes, we do have a Canadian physicians COVID or Canadian neonatology COVID site. It's a private group on Facebook, and someone did post something there about some nurses testing positive, but I don't believe there was an outbreak that I'm aware of yet of COVID-19 in an NICU. One of the things that we may be fortunate in, or not maybe, we're definitely fortunate in, is that COVID-19 does not appear to cause severe disease in pediatrics for the most part. It tends to cause more mild disease, although, as I mentioned yesterday, I certainly do not want to see or wait to see what would happen in an extremely preterm infant who may be immunocompromised.
Dr. Irvie, we have a question from Reem.
So Reem, hi Reem, asks, it is recommended to wear an N95 mask before attending deliveries for babies who may need intubation, such as premature babies, ? So I think, there you have to there you have to differentiate where we're talking about and what we're suspecting. So the recommendation from the CPS was that for deliveries, we do not need to wear the N95 masks if we are intubating a baby, because we don't believe there's vertical transmission. That may change in the future if there are some credible reports that come forward demonstrating that this can happen. But for the most part, we haven't seen that yet. So we're continuing to recommend that we don't need the N95s there. If you're in the NICU, though, we've taken a more pragmatic approach that we don't want people to have to watch a clock wondering when a baby could become positive. We do know that the earliest reported case that I'm aware of was a baby at 36 hours in China who became positive with COVID-19 on a swab. But aside from that, we haven't seen much. So the issue becomes, when does that baby become positive? It certainly was earlier than 36 hours, because that's just when people decided to test. But rather than advising people to, let's say, recommend after 12 hours or 24 hours that people would start to use an N95, it just made more sense so that we didn't miss any. That in the NICU, if you're intubating a newborn with new onset respiratory distress, who is certainly born to a COVID suspect or COVID positive mother, that's where the CPS recommended that we would start to use the N95s.
Dr. Ravi, I have a question from Fatima.
Okay, and I would like to thank Francis, Mary Elizabeth, who has indicated UK guidance for pregnant women by the Royal College of Obstetrics and Gynecology for women over 28 weeks should not have direct patient contact. So thank you for confirming that. The next question was from Fatima. What precautions we need to add in neonatal units during the pandemic? Well, I think that the main precautions are just doing what I think many of us are doing, which is trying to practice social distancing, using proper PPE, and I would say along with that, something that needs to really be addressed is using. When I say using proper PPE, what I'm meaning is using it responsibly. People on the front lines in high-risk situations need those N95 masks, and so we need to be careful that we don't let our fears drive our practice. So if the evidence doesn't support certain situations that need an N95, you might not want to use those, because every time you use one, that's one less that's available for, let's say, an emergency doctor or an ear, nose, and throat doctor. Who may need to be right in the face, doing an aerosolizing procedure, and we need to keep those staff safe.
Dr. V, we have a question from Göktürk.
Thank you for the question. I just wanted to mention again, if you don't mind indicating where you're from, that would be helpful, as I'm curious how far-reaching this is getting. If a baby's born COVID positive, can we think the baby's if a baby's born COVID positive, to a COVID positive patient, can we think the baby's positive? The thinking at the moment, in case you may have tuned in late, but the thinking at the moment is that transmission in utero is not occurring. I've heard rumors that there are case reports coming or case series coming that indicate otherwise, but until we see those in the literature, there just hasn't really been strong evidence that happens. So we don't, or at least the CPS does not, Canadian Pediatric Society has not suggested that we believe strongly that these are vertically transmitted. And as that's the case, we're not treating them as positive at birth. Certainly, as the CPS statement or practice point mentions, it's so critical to practice good hand hygiene and be so careful after birth so that we don't transmit COVID-19 or the coronavirus to these babies.
Dr. Ravi, we have a question from Leah.
Leah, nice to hear from you again. Who does the newborn if he is asymptomatic test, and with which equipment? Newborn. I think that what you may be referring, and I hope I don't misunderstand the question. We would be still recommending, if you're going to test for the virus, that you use a nasopharyngeal swab. I am aware that there are places that are looking at using stool samples to test for the virus as well. I've certainly not done that, nor have I heard that we're going to embark on that. But for now, I would say still the recommendation would be to do nasopharyngeal swabs to test for that.
Dr. Harvey, we have a question from Destiny.
Recommendation. Oh, sorry. This is a looks like a statement actually. Looks like there recommendations by the Society of REI in the U.S. are suspension of all fertility treatments. So that's certainly news. Betsy also responded in answer to questions obstetrical advice. Yes, UK colleagues are advising no patient contact after 28 weeks, so that certainly seems to be consistent.
Dr. Nardi, we have Dr. Nardi, we have a question from, sorry, I just want to make sure I'm not missing anyone. We have a question from, did you already do Betsy? We have a question from Lloyd.
Okay. What do you recommend the neonatal team wear for a delivery if the mom is COVID-19 positive? Is gloves and a surgical mask sufficient? And this person's from South Africa. So what we're recommending right now is that people come in a gown, gloves, and a mask, and eye shields to deliveries. If the qualifier on that, though, is if the mother is going to be intubated, we are recommending that the people who are in the room wear an N95. I was part of a discussion recently where somebody was questioning, if the mother is intubated with a cuff tube, why then do you need to have your N95 mask on, because this would appear to be a closed circuit. And the reason for that has to do with the risk of a pop-off. So if the endotracheal tube detaches from the ventilator accidentally, let's say, as mom's emerging from a general anesthetic, you could release virus into the room if she was indeed positive. So that's the reasoning behind that.
We have a question from Valerie.
Thank you. My assistant's doing a wonderful job today. From Brantford, Ontario. Does a baby need a negative pressure room when intubated or on CPAP or high flow? So that's another great question. We addressed that in the CPS statement as well. The recommendation is if you have a negative pressure room available, this would be the place to put the infant if you have a baby who's intubated with a non-cuff tube or on CPAP. And that's to contain the aerosolized particles in the room and prevent them from going outside. I have to admit, I recognize and had this discussion not that long ago with some other individuals that not everybody has access to a negative pressure room, so we don't want people to worry too much if they don't have one. But certainly if you do have one, that's great. If you don't have one, the key is maintaining that distance, that 6-foot distance or 2-meter distance in metric, just to prevent the spread to other people.
Dr. Nardi, we have a statement that I think you should read.
Okay. By Christina. Okay, from Canada. I haven't read the statement, so I'm trusting my assistant here. From Canada, thank you so much for going live to discuss this topic, as there's not much discussion around the topic in regards to maternal and neonatal care, at least where I am working. I feel like things are changing so quickly around work, which can be difficult to keep up with what is recommended when either caring for a patient or going to deliveries. Keep up the great work, and thanks for the discussion. You are very welcome. And even though that wasn't so much a question as it was a compliment, I think that there's an important point there that I think is worth addressing, and that is having patience with your hospitals. The information is coming fast and furious. Things are changing. People are working on guidelines everywhere. And as the data changes, the requirements for action change. And so there's lots of stuff that's coming out that you might be questioning, why is it only coming out now? But the reason it's only coming out now is because you may have had version 1, 2, 3, 4, 5 that was all ready to go and assist our frontline staff. But due to changes and new information that came, there were substantial delays in getting those out. So I would like to also mention a huge thank you to all the healthcare workers out there, an enormous thank you to all of the people that are sitting on committees nationwide, not just here in Canada, but all over the world, who are spending lots of hours and not getting a lot of sleep, but trying to do the best thing for the people in their community. So thank you for that compliment.
Dr. Irving, you have a question from Penny?
How long is the virus aerosolized in the room? We are wearing N95s during immediate delivery. Then we are instructed to take the N95 off and go to a surgical mask. So Penny, thank you for that question. I'm not an expert in aerosolization, except my understanding is that it can be minutes that those droplets or those aerosolized particles can hang in the air for. So if you have a infection control and prevention, infection prevention and control representative who helps your unit, I would ask that question to them and see what their opinion is on that. But if you search on the web, you will find great resources that talk about how long these particles can spend in the air and how long it takes for them to distribute across the room. But certainly, I think it's more than just a minute that they hang in the air for.
Dr. Irving, we have a question from Charlene.
From Regina, our neighboring province. Should N95s be worn continuously after intubated and has a closed system? So that, I think I'm assuming here you're talking about the newborn. Given that the newborn has, in general, a leak around the endotracheal tube, as long as you're doing direct care for that infant, the recommendation would be to wear an N95. If you are talking about the mother who's intubated and undergoing a general anesthetic, I would say once you leave the room, you can doff your N95. But otherwise, that would be the approach.
Dr. Irving, we have a question from Rosalina.
Do you use a stethoscope in the delivery room if a mother is positive? How do you use it without a risk contamination to you? Yes, people are using stethoscopes. That still remains one of the most important pieces of equipment that we have. I think, like with anything that we're going to use, we have to maintain proper cleaning of all of these things, and now more than ever, I think we need to be absolutely meticulous in cleaning these items. And don't forget, although we all need to be careful and we all need to be cautious when it comes to managing these patients who are COVID suspect or COVID positive, never lose sight of the fact that if we don't stick to the principles that we've all been taught in newborn resuscitation, the outcomes are going to be getting far worse. So stay focused on doing what is needed in the case room, but at the same time, everyone stay safe.
Dr. Irving, we have a question from Leah again.
Oops. Leah, I just lost you. I see. This is a follow-up question from before. And Leah, I'm sorry I misunderstood you. The question was, who is going to be doing the swab for an infant? And with what kind of protection? I think especially if the If the neonate is asymptomatic, then a surgical mask, face shield, gown, gloves are sufficient for the nasopharyngeal swab. But in the event that the baby has significant distress and as well as on any sort of respiratory support, once they're on respiratory support, in the delivery room, I wouldn't worry so much about the N95 because again, we don't believe the infant will be infected at birth. But if you're talking about doing that sampling in the neonatal intensive care unit or on the postpartum ward for a baby that's developed new onset respiratory distress, if they're started on treatment as far as respiratory support, those are infants that I would recommend using the N95s in.
Dr. Irby, that's it for now. Yeah.
Okay. I think that may be all of our questions. I would like to thank everyone sincerely for tuning in. I hope that these sessions are helpful. I would like to just remind people that much of what we have talked about is available at the Canadian Pediatric Society. We have practice points that have been written on these topics. And they are full of great information and being updated weekly if there's new information to share with people. You can also find potentially interesting blog posts at www.allthingsneonatal.com or at Facebook, where I post almost daily, and Twitter is at NICU_musings if you're looking for information there. And I think there's perhaps time for one last question.
There's Dr. Irby, two more questions.
Two more questions. Okay.
The first one is from Afaf again.
Okay. Do you recommend to do a nasopharyngeal swab to well babies of COVID suspected or positive mothers after 36 hours or just to unwell babies? So I think that if the baby is well, that I don't think swabbing them after 36 hours is going to make any difference to their care. If the mother is positive, you're going to be isolating the mother and the baby. So I don't think that would change your management. Sherry, is protective eyewear necessary in an NICU without a COVID diagnosis? That will depend very much on where you are and what your local IPNC recommends. Here we are supposed to be using eye shields and a mask when you're in the direct patient care area. This will, now I know intimately the area you are working in, and when you are not in single patient rooms and there is close proximity to everybody, I would always say to err on the side of caution. You're far better to err on the side of caution than not. And thank you. I do really look forward to seeing where everybody was afterwards who tuned in. I think that, we certainly are a global community. And when I started All Things Neonatal about 5 years ago, the goal was to help people. As a friend of mine from Turkey once asked, when he asked me why I did all this, I said I didn't really know other than I like to teach and I want to help people. So I hope everybody has gotten something out of this today, and I wish you all well, and please stay safe, and we'll see when we do this again. Take care, everybody.